Hello, and welcome to our Fall 2021 series on the well-being of veterans and their families. My name is Ramesh Zacharias, and I'm CEO and Medical Director of the Chronic Pain Center of Excellence for Canadian Veterans.
Before I introduce our speakers for today, I would like to announce the 5 winners of our capacity building initiatives supporting master's and PhD research into veterans' chronic pain. Congratulations to Sarah DeGrace from Dalhousie University, Shanna Deschênes from Université de Québec à Chicoutimi, Julia Kelty from the University of New Brunswick, Hélène Lesseleur from Université d'Ottawa, and Meredith Seeger from the University of Manitoba. I would also like to acknowledge our research director, Dr. Jason Bussa, whose rapid recommendations on the use of cannabis for chronic pain was recently published in the Journal of Military, Veteran, and Family Health. The article is now posted on our website for those who wish to read it. I would like to take this opportunity to thank our presenters today. Our first presenters are Dr. Jim Thompson from CIMVER and Tom Hoppe, the chair of our Advisory Council of Veterans, who will be speaking on veteran identity. After our first presenters, we will have Tom Carter, Dr. Elisabeth Saxton, and Eryn Weldon from CBI Health. Thank you for joining us today. Now I'd like to present our moderator for this session, retired Lieutenant General Michel Maisonneuve.
Merci beaucoup, Dr. Zacharias. Et encore une fois,
Thank you,
bonjour,
Dr.
chers amis.
Zacharias, and
On behalf of the Chronic Pain Center of Excellence for Canadian Veterans, I welcome you to the second in our series of webinars on veteran and family well-being. Today again, where there are 2 streams to choose from, a French language stream and an English language stream. We're doing simultaneous translation so we can serve both streams, and all the support material has been translated. You should also be aware that the presentations and slides are best seen in full screen mode. Les 2 présentations aujourd'hui seront en anglais, mais avec traduction simultanée et diapos en français dans la version française.
French slides.
I'm honored to help moderate this webinar. The Center of Excellence on Chronic Pain is doing excellent work that has already helped many of our veterans who suffer from chronic pain, as well as their families. Chronic pain is a constant in the lives of many of our serving sailors, soldiers, and airmen and women. And for many of them, this pain follows them into retirement. Today, we're going to focus on the issue of identity and its effect on veterans' views of themselves, especially during their transition from the military and their reintegration into civilian life. Identity issues have an impact on the chronic pain some of our veterans live with. Notre webinaire aujourd'hui traitera d'identité et de la façon que les
This
vétérans se
webinar
perçoivent
deals with
eux-mêmes. Une
identity
question importante,
and
surtout
veterans' view
lors
of
de la
themselves.
transition des militaires à la
This
vie
is
civile.
especially important
Et cette question
during
a définitivement
transition
un
from
impact
military
sur
to
la
civilian
douleur
life,
chronique ressentie
and this has an
par
impact on the
certains de nos
chronic
vétérans.
pain that some of our
We will
veterans
have
live
2
with.
presentations, and as usual, we will take questions after each. I would now like to introduce our first presenters, Dr. Jim Thompson and a veteran, Mr. Tom Hoppe. Dr. Thompson is a research medical consultant working with the Canadian Institute for Military and Veterans Health Research. He's also an associate professor with Queen's University and Dalhousie University. Dr. Thompson served in the Canadian Armed Forces Reserves Infantry and has practiced family and emergency medicine in Alberta and Prince Edward Island. As the research medical advisor at Veterans Affairs Canada from 2005 to 2019, he led the conceptualization of the framework known as the 7 domains of veterans' well-being. Dr. Thompson is an associate editor of the Journal of Military and Veteran Health Research and has over 100 scientific publications. He collaborates internationally in research on the multidimensional well-being of military veterans and their families. His co-presenter is veteran Tom Hoppe. He is chair of the Center of Excellence Advisory Council for Veterans. Tom joined the Canadian Armed Forces in 1982 and served with distinction during a career spanning 20 years, which were followed by a career in public safety and security. In 1994, while serving in Bosnia, Tom rescued 3 children who were being shot at by snipers, and he successfully commanded his patrol during several engagements with opposing forces. In recognition of his conspicuous leadership and bravery under fire, the Governor General awarded Tom with both the Meritorious Service Cross and the Medal of Bravery. Following his military career, Tom completed a business administration and human resources program, along with a Master of Arts in leadership and training focused on organizational leadership and the coaching transition needs of veterans. Since 1998, Tom has been actively involved in modern-day veterans issues. Their presentation today is entitled Veterans Identities, a Key to Success in Chronic Pain Care. And as you will see, the change in identity has an impact on individuals when they leave the military, especially as it relates to those with chronic pain. Messieurs, à vous.
Good day, everybody. My name is Tom Hoppe, and I'm joined with Dr. Jim Thompson. Today, we're going to talk about veterans' identities, a key to success in a chronic pain care center. Participants are going to be able to understand how veterans' personal identities and social identities form and why they are important. And we're also going to talk about a few strategies to help veterans in a pain clinic. So what I'd like to do is I'd like to turn it over to Dr. Jim Thompson to start us off, and then I'll follow his presentation. Jim?
Thanks, Tom. So during our presentation, think about this sort of fictitious case of a new veteran who comes to your clinic. Someone's maybe 30 years old, they've had chronic pain in service, but they released involuntarily, like a medical release 2 years ago. They finally got help from a family doctor and then got referred to your pain clinic by a VAC case manager. And the veteran shows up and it becomes clear that they kind of feel like a fish out of water at this point. So it's the intake visit. There are lots of variations on this theme, but think of something like that while we're talking. Next slide, Tom. A lot of people have found this slide useful in thinking about how all this works. And a child, when it's first born, starts to have a sense of social identity, a sense of family, how they're like other people. They identify with their mother and with the immediate family around them. And then as they age, they start to develop a sense of personal identity, who I am, how I'm different from everyone else, not the same as a social identity, but different personal identity. And in adolescence, that becomes a pretty big deal, of course, where they start experimenting with different kinds of identities. They can enter the military before they've got a fully formed adult identity, civilian identity, or they can enter earlier, and some maybe even were practicing entry as cadets and then entered as a reservist in their adolescent years. So we're developing their identity at the same time that they're immersed in the military. And then during enrollment, in transition into the military boot camp, there's a deliberate attempt to start to get them to identify with the unit around them, start becoming green or blue, for example. They start adopting the norms and values of the unit that they're training in. It's not just about them anymore. It's about the people around them. Higher vaccination rates in the military than civilians are kind of attest to this, I think, to this identity that starts to happen where they get outside themselves. So the military identity starts to form. Then during service, they get very immersed in that military identity, in that culture. And the identity starts to form because of the immersion in the culture. Even reservists get very immersed in that. They identify strongly with the military, or at least in different degrees. They identify with different military subcultures, different units, different garrisons, different ships, and these subcultures affect the way that they think and behave and influence the identities that they begin to develop. But they still have within them their civilian identities that they had prior to service, and they could even be forming new civilian identities while they're in service. Like, for example, the member who goes home from off base at the end of the day, takes off their military uniform, puts on a coach's uniform and goes and coaches a civilian hockey team. And then the next day, she goes back on base and has her uniform back on, and then her military identity becomes salient. It comes to the forefront so that she can function in that military culture again. We flip back and forth between these multiple identities that we have. Then in transition to post-service life, the identities get challenged. The person isn't sure who they are anymore and who they belong to anymore. in some cases. Sometimes they've got a very strongly formed civilian identity they just step into, like, for example, a healthcare practitioner who's working in the same hospital and just takes the uniform off. Others go through much more strong identity disruption. But all of them will have to eventually develop a post-service veteran identity. It's not like they become civilians. They learn to function in a civilian culture with that identity. So that's what's happening. Then in the transition, that can become very challenging. If they've developed something like chronic pain, then it's even more of a challenge, because they're going from a person who is very fit and athletic, perhaps, to someone now who's got chronic pain that limits what they can do. So there's a loss of identity in that regard too. We're very social creatures. We do better when we live in social groups that accept and understand us and where we feel comfortable. That's where we develop social identities, the membership in these groups. Major life transitions occur when we move from one culture to another, like civilian life to the military, or military back to civilian life. And there are other major transitions that members go through too, like that in life. And our identities get disrupted during those transitions, and they have to heal in a way that leaves us better equipped to get along in life after service or after the transition. We never stop having identity crises. They occur throughout our lifetimes. We just have to learn how to deal with them. Every military member has a different transition. No two are the same. Who I am, that sense of personal identity, can get hit pretty hard when they leave the military. And so can their social identity. Who do I belong to, and how do I relate to these people I'm finding myself around now? Going from being a healthy, active soldier, sailor, air person to a person living with chronic pain is a big life transition that can complicate the other transitions. That's feeling that I was strong, now I'm broken. Instead of I was a soldier, now I'm a veteran with chronic pain, and I'm in a good place in life after service. Two ways of telling that story. It's important to beware of toxic stereotypes. We all identify other people using short forms called stereotypes. And the problem is that bad stereotypes are very bad. They don't reflect who the person really is, but that person ends up getting treated according to the stereotype that they're being labeled with. But good stereotypes, ones that reflect who the person really is, are really good. So veterans and everyone else need to understand how other people's identities are in crisis when they go through these kinds of major life transitions. And it helps if we understand how the military culture and chronic pain changes military members, how those changes could be causing stress for them in the civilian culture that they're immersed in now, and how their military identities affect their mindsets. And that's what Tom's going to talk about. Tom?
Thank you, Jim. So what I'd like to talk about now is just look at, in the next few minutes, talk about some of the issues that veterans face entering a chronic pain clinic, and also some strategies that could help. The information I'm going to talk about today is some of it's come from a qualitative study conducted by the CPCOE, and the other one is from a small coaching program that we did at Change Pain, which is a multidisciplinary pain clinic here in Vancouver, as well as the last 18 years of working with veterans. So we know that culture and identity can be confused. When I talk to many veterans and even non-veterans, some people will better identify with culture than they do with identity theory. But we know that culture actually is the environment for identity to be formed. And when we think about it, basic training is a good example of this. As Jim had said, when someone enters the military, they're entering with their civilian identity. However, the norms and values of the military culture, be it mission first, team, regiment, self last, or no pacing, you just push through, institutionalized directive culture that we're in. These things slowly start to change a person. And over time in the military service, a person's identity starts to change. And it can happen very slowly. And they may not see that they have changed. So some of the veterans we've worked with, they don't realize that they have changed. They think the civilian world has changed. And we see this sometimes in our training. If someone is not strong enough or not being able to push through an event or an obstacle, they may be told that, hey, what are you, weak? Are you a civilian? Depending on who the instructor is. So that reinforces that the civilian world is much different. But it's actually us who've changed. We've heard military and veterans say when they go to a new workplace, when they've left the service, these civilians are late, they're not on time, they can't plan properly. These are all things that were taught to us when we were in the military so that we could work properly in that environment. So we find that what helps with coaching the vets is them understanding that they have changed. And many, and myself included, many people who are leaving the service, prior to leaving the service, you may say to them, hey, it's going to be different when you get out. There's going to be a transition period. They may understand it, but not fully know about it. And I know a good friend of mine who went through this process. He got a good job as an engineering firm. And he said to me when I ran into him at the gym a number of months after he was out, he said, Tom, I thought this would be like another posting getting out of the military. You could see that he was struggling with the identity change, and he himself couldn't understand why it was happening, but he knew something was different. So this is important to understand. So what can we do to help veterans who have chronic pain and may come into a clinic? One thing that came out of the qualitative study, and also from talking to other veterans, is that veterans feel that practitioners do not fully understand them or their culture. So this is one thing that could be helpful, is to help educate clinicians and medical practitioners and staff on what military culture is. Because one thing that we learn in the military is we do not disclose all our medical information because it's a fear that it can impact our career. Also, some veterans who may not fully understand Veterans Affairs policies and procedures may feel that if they disclose information, it could affect their Veterans Affairs benefits. So understanding this, that is part of our culture, and also we just push through, we don't acknowledge pain, may help a practitioner better relate to the veteran. Using a qualified coach to help veterans integrate into a pain clinic is also helpful. Where we trialed, we had a coach and a doctor, we bridged that gap. So you can imagine a veteran who is trying to adjust into the civilian world, coming from a directive culture where they've been told what to do, and then moving into a loose, free culture such as civilian life, also struggling with chronic pain, possibly PTSD, and now they come into a very busy clinic, not understanding what's going on. It could be overwhelming. So by taking that approach where you bridge the two cultures, educate the veteran on pain programs, on what's going to happen, and how things are going to move forward, can help lessen that anxiety and help build that relationship. Also, veterans do well in a pain program. Well, what happens when they leave 3-4 months down the road? Because of the identity and cultural challenges that they're facing, perhaps they will struggle with their chronic pain. We look at some veterans who reported back in the Invictus Games, they were pumped, it was great. But once they got home, they had a crash because the purpose was gone. They're still struggling with identity. So it's important to have some kind of follow-up after a person comes out of a pain program. So next we talk about is educating veterans on the biopsychosocial of chronic pain. So education is always important, but we need to link it to identity and culture. So someone who's struggling with chronic pain, as Jim talked about, they were fit before, they had purpose, they were an athlete, and now they're struggling with this chronic pain. But unlike other pain patients, we also have culture and identity that is in the mix. And so it's important to educate veterans on the biopsychosocial of this. As well, if you take a look at any research that comes out, we have to account for the differences between military and civilian. So we know that there is a difference between military culture and civilian, but there may be some crossovers. For example, if we look at emergency services, or consider paramilitary, there is some crossover, but there are very differences. For example, emergency services have a limited right of refusal. They have the ability to, it's self first, patient last. Military, there is no limited right of refusal. It's mission first. Self is very much last. And so the mindset is very much different. Where in the military, you just suck it up, move forward, because you can't stop the mission is got to be completed. Plus, in the military, it's a very directive culture. And even though there is tie into civilian, as Jim said, where someone may go do something on the civilian side, they're very much in the military identity. And these were some of the struggles come out. The structured peer support can also help veterans. We know from the qualitative study, veterans are looking for peer support, but structured peer support. The peer themselves, I would suggest, has had to go through their own identity and changes, and also understand the difference between the military and civilian culture and the changes a person goes through in order to help someone else through that. But by that connection of a peer is important, but also being able to educate the veteran to move forward with their challenges that they're facing and to understand the changes that they're going through. And this is also important when we look at a transition action plan. This is something that a veteran can carry with them once they leave a program. It has in there the team that they've worked with and also goals and objectives for them to move forward with their transition. So these are just a few quick pointers. There's quite a bit more to discuss, and both myself and Jim will be available for questions. Thank you.
Bien, alors merci beaucoup Jim et Tom pour cette présentation. I was fascinated by the question of identity when I first heard this presentation, and I must admit I felt the issue of change in identity myself, but I did not understand its impact on chronic pain, nor did I understand or realize that change was happening. So we've had the audience submit questions in advance, and I'm going to ask our presenters to respond to these over the next few minutes. So the first question is, what are some of the challenges a veteran might face with their changing identity as they transition out of the military?
Tom and I talked about how to respond here. I'll go with a sort of research view, and then Tom will fill in some of the realities. So I think I've suggested feelings of being stressed without knowing why. If their military identities are coming forward in civilian settings before they've begun to identify with the civilian culture they're now living in, they might feel out of place, unease at best, and even a lot of distress at worst. Tom, what do you think?
I think you're right there, Jim. You know, some of the veterans we've spoken to and we've worked with, you know, depending on the qualifications and trade a person comes out with, there's a sense of feeling, almost the analogy that, you know, a tornado's gone through the farm and you're standing there in the empty field and you have to rebuild your life from nothing. And so when we throw chronic pain into that, I mean, that just adds the complexity. We look at things like network or job connections. Once someone gets out and you're starting from fresh, you know, if you enter a job and you have your civilian peer beside you, they've had 20 years of experience in that position to move forward, and you're starting from fresh. So those are some of the challenges that can impact on identity because we're struggling with that change. It can be overwhelming.
So when an individual transitions out of the military, you know, how much time would it take for their identity to kind of catch up to them?
Every veteran's journey is different. No two are exactly the same. Some leave the military with civilian identities preformed, as I talked about in that presentation, that example of maybe uniformed healthcare providers who take the uniform off but stay in the same hospital or clinic. And on the other extreme, we've heard stories of veterans who seem to go a lifetime not feeling like they fit in. Most or many are probably somewhere in between. The key is that it takes time to adapt whenever we do a major life transition. So patience and encouragement are required if the going gets tough.
Yeah, I think that's the important note, is not every transition is the same. I mean, there's some commonality, as we've discussed in the past. I think, you know, if we look at intensity too, this comes up at times compared to, say, someone who's in infantry versus someone who's working a 9-to-5 job, the intensity is going to be different. There's some commonalities there. And I think the key here that we have discovered is a veteran has to understand that they have changed. And perhaps this helps with the identity, the length of time of this whole identity crisis that they're going through. But understanding that we have changed when we're coming into service is important. And I think that's an important step to move forward with identity change.
Yeah, in fact, that's what I was referring to when I heard the presentation, and that was only about a year ago. I was flabbergasted because I never realized that we all go through this, and as you say, at different levels. Now, coming back to the issue of chronic pain, how does that impact a change in identity, the change of identity of an individual who goes through this and has chronic pain?
It's a complex question. It hasn't been all sorted out yet, I don't think. Lots of people have been working on this for a lot of years. Developing chronic pain can challenge a person's sense of who they are and how they fit into society. So therefore their personal and their social identities before they leave the military, and then again after, making the transition even more complex. There's some really fascinating emerging evidence from brain imaging studies, like, for example, that Ruth Lanius and her colleagues are doing, that parts of the brain that maintain a sense of self and identity can be changed and then can heal in some psychiatric conditions. So now there's a lot of interest in seeing if there are similar changes in chronic pain situations, which can promote healing too. Tom?
Yeah, I think you're right. It is. I mean, some of the research I'm involved with now, it's trying to find that balance and also trying to have a better understanding. I mean, mindset is important to this. I think when we look at veterans, pain is a layered approach, and if we look at what's unique to veterans, let's talk about the mindset of mission first, team, regimen, and self. And if that's the case, I put myself last. So how does that impact for my, my own pain? Do I push through? Do I downplay what's actually happening to me? And what impact does that have on family and approach to treatment? And I think this is where we go back talking, we found is educating veterans on what is pain management, biopsychosocial, and how that could help them better understand to move forward. Because if we look at, if someone's struggling, they come out of a pain program and they're doing well, and then they go home and they're still struggling with the identity challenges, and they just end up sitting on the couch because they can't move forward, then how does that impact their pain? How does it impact their treatment program, sleep, nutrition, all those things? So I think it's important to look at how the culture and the mindset will impact the overall treatment when a veteran is moving forward.
Very interesting. And I guess kind of now going back to the beginning and what happens when an individual joins the military, do you think that at this point an individual loses their sense of self, I guess, to a certain extent when they join the military, and that therefore has an impact on when they leave the military?
I haven't read a lot about this and thought a lot about it, but to me, sense of self is something different and deeper than personal identity and social identity. But those three things are all wrapped up together. What I've read suggests that recruit training works to get recruits to identify personally and socially with the military unit and the culture around them, adopt their norms and values of that culture so they can function well in it. But people need to have a sense of self in order to function. So I don't think calling it losing their sense of self. In fact, it's probably better to, rather than talking about selflessness, it would be better to talk about the adopted value of putting other selves before one's own self.
I agree with you, Jim, on that one. I think, if I think back to even my own time going through the service, is you're just put into that environment and that culture. Of course, you're sleep deprived, all those techniques they use to change your view and to fit into that culture are completed, but you're still your own person in many ways. So.
Yeah, and you made me think when I think of this is I guess at times you hear a lot about some of our folks getting out and then rejoining a few years later, and I guess because they want to recapture that identity that they had at that point. I guess one last question is, so what are the steps to ensure that our veterans know about the importance of this change in identity, and that what they're going through is a normal thing?
Well, that's a question Tom and I and colleagues have been working on, trying to figure out how to translate this knowledge into something that's meaningful. And that's why I've enjoyed so much working with Tom on this, because he brings that lived experience together with what I've been reading about in the literature and working with. But yeah, that's the challenge. We need to figure out ways of making this meaningful for members and veterans who are going through these transitions. Tom?
I agree. I think being able to understand the research, working with Jim and his team, and also working with the veterans, is trying to bridge between the research and the practicality. I think this is where the peer support is important. But when I say peer, I'm going to say more of a coach. But the coach themselves, as I said in the presentation, should have gone through some of their own change. Because this is some of the feedback we've had, is some veterans say the peer support program works well. However, the peers that they happen to be working with at that time were still in the military mindset. They still hadn't transitioned, so they couldn't move. They said, the feedback was, I couldn't move forward. So I think that's important, and education is important. And this is what we've done with our program: is we go through and educate the veteran that they have changed, and give them the understanding. Try to bring in the research that Jim and his team have been working on, and kind of boil that down and provide that understanding to the veteran, and hoping that will give them to move forward. And Michelle, I mean, as well as I do, we can be out of the service for many, many years, and it's still there. But we have to recognize that and just work with it.
I guess keeping the best parts and letting go of the rest. That's probably the key to it. But thank you very much for these. Merci beaucoup, Jim et Tom, pour cette excellente présentation. Et merci
Dr. Thompson.
à tous nos
Thank
participants
you,
pour vos questions. Je vous
Tom
rappelle
Hoppe
que les présentations sont
for these
disponibles sur le
excellent
site web
presentations.
du
I'll
Centre
remind you that
d'Excellence
the presentations will be
et que vous
available
pouvez nous
on
contacter
the
pour toute
website
question
of the
que
Center
vous
of
auriez
Excellence, and you can
maintenant.
contact us
Nous allons
for
maintenant
any
continuer
question.
avec notre
We will now
deuxième
move on to the
présentation. On
second
carry on with our
presentation.
second presentation. Nous allons maintenant progresser de la
We'll
notion
now move on
d'identité à
from the
celle de
notion of
la
identity
réintégration. Nos
to
invités
the
suivants
notion
sont
of
M. Tom Carter, la
reintegration.
Dr.
Our
Elisabeth
guests are
Saxton,
Tom Carter,
Madame
Dr.
Eryn
Elisabeth
Weldon,
Saxton,
et le
Eryn
vétéran
Weldon,
Doug Zwicker.
and veteran
First,
Doug
Tom
Zwicker.
Carter, who is National Director, Clinical Excellence. He completed his MSc, Master of Science, at the University of Toronto in the Graduate Department of Rehabilitation Sciences. His research interests involved the interdisciplinary management of injuries and the field of health services. He has held the appointment of adjunct lecturer in the School of Physiotherapy, Faculty of Medicine at the University of Toronto. Tom has 27 years of experience in a variety of rehabilitation settings across Canada, New Zealand, and the United States. Dr. Elisabeth Saxton is National Director of Mental Health Services, CBI Health. She graduated in clinical psychology in 2005, and after a period working with children and teens doing assessment and treatment, she found her passion in interdisciplinary rehabilitation. She joined Orion Health in 2009, which became part of CBI Health Group in 2015. She has remained a part of the treatment team, but became increasingly involved in assessment, program development, and program evaluation, while encouraging innovation in treatment. She's currently the president-elect for the Pain Society of Alberta, a nonprofit society that supports education and awareness for healthcare practitioners treating people living with chronic pain. Ms. Eryn Weldon is an occupational therapist who works with veterans in the pain management programs in Atlantic Canada. A graduate of the University of Ottawa and the University of Toronto, she holds a Master of Science in Occupational Therapy. Ms. Weldon is an accomplished athlete and has won numerous swimming medals at the provincial level. She's currently the regional manager at CBI Health in New Brunswick. And finally, veteran Doug Zwicker, a structural technician who served in the Royal Canadian Air Force and was injured while on deployment in Haiti in 1997. Doug lives in Mahone Bay, Nova Scotia. After following a number of unsuccessful pain programs for almost 20 years, Doug was able to finally get the help he needed through the CBI pain program. I'm sure you'll find his personal testimony convincing. Our four guests will join us today to discuss how they work to reconnect veterans with their families, their hobbies, and their lives. Mesdames et messieurs, la parole est à vous.
Thank you, sir, for that kind introduction. On behalf of the entire presentation team, we are excited to be able to discuss today an important part of developing the identities and supporting veterans in their communities, and how we do so through our pain management program. At CBI Health, for over 45 years, where we began as a back education group and have become now a leading provider of community services across Canada. We're very excited that 6 of our clinics in British Columbia, Alberta, New Brunswick, and Nova Scotia are able to be part of the Chronic Pain Center of Excellence. This is where better begins in terms of helping those who have served our country be able to integrate back into their communities in a more effective way. CBI Health provides services to over 300,000 people each year through our home health services, our specialized community living, as well as our rehab group of clinics. But in terms of our rehab group of clinics, what we want to speak about today are a group of veterans that we are very excited to be able to provide motivation and support to be able to help them to return to their lives. We see about 110 people a year through our pain management programs. And we'd like to speak to you today about how we utilize that program to really effectively help people integrate back to their communities. So I'm going to turn this over to our National Director of Mental Health, Dr. Elisabeth Saxton, and our Regional Manager, Ms. Eryn Weldon, who's an occupational therapist, to speak more about the program.
Thank you, Tom. So essentially, when we developed the pain management program, there's a lot of services that people have potentially tried and done it through single service. And when we look at the evidence and the research, it really supports more of an interdisciplinary approach. So building on our history in rehabilitation, we formulated an interdisciplinary team, and we developed a program that is biopsychosocial, spiritual focused, and definitely has an overlay of acceptance and commitment therapy in terms of the approach to pain management. So what that means is it really is about tying into an individual's values. So not necessarily looking at what their barriers are in terms of what they can't do, but really starting to develop those goals around what it is that is most important to them in their life. And by recognizing that, we can reverse engineer that to develop those goals and have that commitment to action, as well as that awareness so that they can recognize the improvements that they're making. Other key components of this program involve that self-regulation piece around mindfulness, relaxation training, and just the mind-body connection, emphasizing behavioral activation and physical function and that rehabilitation component, recognizing that they can't just do well in clinic, they need to be able to function in the community in a real world setting, and then involving that medication management piece and ensuring that they are medically cleared to participate in a more intensive rehabilitation program. So in terms of all of these services that we're delivering, this isn't going to be necessarily done in individual sessions or 1 hour once a week. This is really more of an intensive program. So the program days tend to be longer as all the services are centered in one place. So overall, they're engaging in more hours during the week. It can be really challenging at the get-go, but it also serves a purpose. It serves to increase their overall tolerance and challenge that level of function that they're at when they get to our clinics. In terms of the team itself, it is built around the veteran, and we very much want individuals to feel like they are a part of the team. They aren't the person that we're working on, they're the person that we are working with. On our side, we have physicians, psychologists, psychotherapists or clinical counselors, physiotherapists, kinesiologists, and occupational therapists. Now, if needed, occasionally we can bring in a pharmacist as well. And what we emphasize in terms of the nitty gritty and when we're really creating those targets, we want to focus on the barriers to reestablishment. So getting to those activities of daily living, that community participation, so that it's not just what's happening in the clinic again, we're transitioning into that community participation, their family roles, the instrumental activities of daily living. So the things that you need to do to function as a family. So going out and getting your groceries, going shopping, driving kids back and forth to school, and then the vocational or avocational role. So whether that's volunteering, whether it's employment, we want to make sure that we're addressing those needs as well. So that allows us the ability to really get more specific in creating how we're going to set those goals and where we're heading in the program. So today we are going to be honored with the presence of Doug, who's going to be speaking to us in a second. And we really want to focus on his journey. So initially, Doug had mentioned he'd had some treatment in the past, was still struggling. So he reached out to his case manager to basically ask what else can be done and what else can be provided in terms of support to help him with his pain. His case manager identified that there is the availability of the interdisciplinary program in Halifax, and then basically started initiating the process of referral. So we take the information we provide that's provided to us from the VAC case manager and start the ball rolling in terms of booking the assessment, which is a bit of a longer assessment. We recognize that. But again, it's an interdisciplinary assessment, looking at all of those different disciplines and those different aspects. So from that, if appropriate, we make recommendations. And in Doug's case, the recommendation was to move into a tailored program. So once someone comes in, we start really tailoring it after the interdisciplinary assessment, looking at the specific barriers they're experiencing and starting to tap into what are the values that they aren't necessarily aligned to right now, given their current level of functioning. And given that this can be a lot of information to present to someone in a short period of time, we really try and layer that intervention and build upon the basics. And the basics, when people move into the programming, are around education. So much of the research highlights that education is a key component in terms of pain management, alongside the specific interventions that are specific to each discipline. So there's going to be individual sessions with the psychologist, occupational therapist, kinesiologist, physiotherapist. So that's the treatment side of things. At the same time, we're looking for people to begin becoming more engaged. So not only is it going to be active, so again, the treatment isn't being done to you, it's being done with you. There's also engagement, not only as part of the team with the other professionals, but also group components as well. So the education sessions, the regulation trainings, such as mindfulness, it is more of a group component. So there's a level of engagement that you're engaging with other veterans, as well as some individuals who may or may not be veterans. And then the big piece is recognizing it's great if you can do it in the clinic, but we don't need you to be able to do this for the weeks that you're attending the program. We want you to be able to take this and have it continue and be sustainable for not just the next weeks following, but moving forward. And to do that, we needed to tie that into the community. And I'm going to let Eryn take it over to talk about that component.
Great, thanks, Liz. A really exciting part that we wanted to talk about today is the community integration activities that take place within our Veterans Affairs programs here at CBI. So our community integration activities would be a group event that takes place with veterans and sometimes other clients who are participating in a pain management program, where there'll be a group facilitated by an occupational therapist, where the group will identify an activity within the community that they would like to work on that week that would help them build their independence in their own community and work towards the goals that they had identified within their beginning parts of their program. So the OT will help work on communication skills, will help facilitate the veterans to break down barriers for accessing these activities in the community. We have done things like cooking classes, attend fitness centers where they'll be able to continue with their home exercise program, or look at different opportunities for pool therapy or other leisure activities in the community. We really saw that by targeting these avoidance behaviors and working through the barriers that keep our clients from accessing these community events really helped to elongate the sustained improvement of functionality and build that into the community.
So now we're going to bring in our star, Doug, and give us a little more detail around his own journey. So Doug, welcome. And I'm wondering if we could just start with you sharing a little bit about what struggles you were having before you came to the program.
Before I came to the program, I was having difficulty. Over a period of time, my mobility was actually decreasing. And with the decrease in the mobility became the withdrawal from society and dealing with family and friends. And and all that aspect of it, along with sleep habits, eating habits. They all go kind of hand in hand. And, you know, through coming to the CBI clinic, actually, it's quite amazing how much I've actually grown from that.
So, speaking specifically to the program itself, what was it like, that experience of coming into the clinic and going through the in-clinic parts of the program?
Initially, when the first assessment was done by the doctor, and they actually got the ball rolling and got me enrolled here at CBI in Halifax, one of the first things was a meeting that they actually sat me down and they asked me what I would like to get out of this program. Like, what are my goals? What would I like to improve on? I've been involved in different physiotherapy centers or whatever in the past. That's never been asked. This is the first time ever that I've actually been asked what I want to get out of it, not what they're just going to do to me. Very first time ever. And actually, I felt like a team member, not a client. Like, they literally came together and brought everything, tailored it to me and what my needs were, not what they thought I should have. It was a huge eye opener for me.
So were there some aspects that really resonated with you in terms of the programming that you were involved in the clinic?
Actually, I learned how to say no. I'm the type of person that if somebody asks me to do something, irregardless of my pain management, my pain levels, I'm there, right? If it's shingle on the roof, I'm there. I don't tell them that I'm struggling, but I'm usually the first one there. I'm always the first one there. And people rely on that. And to actually sit back now and say, I'm very sorry, but you know what? I'm not at my best right now. I'm going to have to say no. That was one of my biggest struggles. And I've struggled with that for years and years and years. And I will probably continue to struggle a bit. But there are certain things that, you know, I know physically now that there's, you know, I am getting better. I'm gaining more mobility. But there's times I'm just going to have to say, I'm sorry, but I have to pass, right? You know, and it is a struggle for me to deal with that aspect of it. Yeah. From being go, 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 go to stop. And, you know, my daughter actually just recently, I had a fall after I finished the CBI program and did a little damage to my shoulder. And she said, Dad, she said, you can't sit home because you're not going to heal. So she said, come visit. So I actually got out of my comfort zone and I actually took my first flight in 12 years and actually went to Edmonton for a visit to see my daughter and granddaughter. Right? I mean, and now I can't wait to go again.
So you did mention that you are getting better. Functionally, how are you different now than before the program?
On my property, I'm located up on top of a hill. So if I want to go to the lower level of my property, there's two quite steep hills. Before the program, I avoided them. I would actually jump in my truck and drive down and then get out and walk around. Now I can actually physically walk up and down that hill without difficulty or without falling. So it's a huge bonus for me. I mean, I continue to do the exercise program and working on a lot of the other aspects of saying no to people, trying to eat healthier on a regular basis, which is a really bad habit of mine. I'm a one-person meal a day. So now I'm up to 2, so which is a big, huge improvement. Right? And without the CBI clinic and all the help here, I don't know where it would be today. I was grasping at straws before I came into the CBI clinic.
Well, and it sounds like you've been able to reconnect for the first time in many, many moons physically with your family in Western Canada. How have you reconnected with your community closer to home?
I'm actually getting out. I have a few other veteran friends and getting out, going for coffee. Before I come in here this morning, a friend of mine stopped by. Another friend of ours, his father had passed away over the weekend. And he said, Doug, he said, get ready and let's go. He said, we got to go see him, right? I haven't seen the gentleman for quite a few years. And I was kind of hesitant. And I said, no, this is something I have to do. Normally, I would not go. I would just avoid, make excuses. But I actually got ready and actually went down and had a visit. And I'm actually glad that I did, right? They're both, the father and the son are really good people, right? Yeah. And they were very appreciative of me actually showing up. So just getting out there and doing a little bit more is a bonus. Right?
Well, I really appreciate you sharing your story. Is there anything else that you want to share before we move on?
Actually, I want to thank the staff at the CBI clinic, and without their help, in the past 3 or 4 months, like I say, I really don't know where I would be. I was actually starting to become a recluse and not wanting to go anywhere. And to break me out of that shell, like I said, I cannot say enough good about CBI clinic and the staff that is employed with them. They're excellent. I've actually told several veterans about the program that I've taken, and they've actually seen the difference in me as well. And they're all like, okay, how do we get in contact and how do we get to go into this program? I mean, tell your case manager. If your case manager doesn't know, get in contact with tell them to contact my case manager, and we'll go from there. But the biggest thing that we're finding right now through the veteran community is people not knowing what services are out there and what is available. I've had veterans here at CBI come up to me and ask me about their health card through Blue Cross. They don't know what they're covered for. I didn't know what I was covered for. I didn't realize until recently through my Blue Cross coverage that there was 20 physiotherapy appointments I could have had per year and 20 massage therapy sessions I could have had. Didn't know. 21 years later. Mm-hmm. And I'm just finding out now.
Well, I very much appreciate that you are not only sharing your story with us, but you are sharing it with other veterans. And by sharing your story alone, you're telling people about what you can do instead of, it sounds like previously, really being limited to what you couldn't do. And I'm all about you getting outside of your comfort zone. And I'm sure part of that includes coming here and spending this time with us on camera. So thank you so much for sharing your story. And I hope you continue to tell it to others.
Okay. Thank you very much.
Thanks, Doug.
So just tying it back to making a meaningful difference in the lives of these veterans. As we move through our pain management program, we're continuously monitoring the improvement within these barriers to reestablishment. So as we talked about earlier, looking at those improvements in our ability to complete our activities of daily living, community participation, family roles, instrumental activities of daily living, and our vocational or avocational roles. So as we heard in Doug's story, he was able to make some significant improvement in each of those domains, which was so great to see. Our pain management programs are individualized to the needs of the veterans, so can vary in number of total treatment days, usually ranging from 18 treatment days to 50 treatment days, depending on the complexity of the injuries and of the veterans. For Doug's journey, he was able to complete his program within 43 visits. And we see there the average number of treatment days being 31 visits, which equates to our 124 hours of intervention, which aligns to our best practice, as Liz was speaking to earlier in the presentation. So I'll hand it over to Liz to talk a little bit more about some of our other outcomes.
So when we look at sort of the goals, at the end of the day, a lot of veterans come in and they're looking for that shift in community, just like Doug. They want to not be sheltered in and rather be engaged and participating in the greater community. That may include family, it may include a veteran cohort, it may be just more engaged in different aspects of their social, spiritual community. 73% have those as identified as their goals. However, we do have a subset of about 27% who also have a vocational goal. Now, that might be a new occupation, it may be something that they're moving towards, or they're wanting to return to that, or it's a job that they weren't able to continue with. So we can definitely tie in that return to work piece and have that occupational component as part of the program as well. And it's great to hear those stories, and they are without question the best way to share the difference that can happen with our programming. However, we also want to be able to demonstrate that we can do this on a larger scale. So we do have pre-post outcomes. When we look at the clinical change that we see among our veterans, the blue is the intake, the purple is the discharge scores. And with pain management, we're really not talking about pain severity. The goal of the program, as you've heard, is not about changing your experience of pain or making the pain go away. It's about changing the relationship you have with that pain and identifying for yourself what it is that you want to have in your life and how to work with pain as a partner to be able to achieve those. So rather than saying we're going to make the pain severity reduce, we really look at pain interference, we look at pain catastrophizing, and also increasing things like motivation and reducing avoidance by changing measures of depression and anxiety. And overall, we also want to make people be more resilient. So that ability to bounce back, knowing that with chronic pain, it is going to ebb and flow, and being able to have a bad day and be able to get back in the swing of things afterwards. So looking at our outcomes, we do see clinically significant changes in resilience going up and reductions in all of those other components around interference, catastrophizing, depression, and anxiety, which is really what we want to see. So while a lot of times individuals may come to the clinic wanting to feel better and wanting to get rid of their pain, it's not necessarily what we're targeting. We don't want people to simply feel better. We want them to actually, in a very real, concrete, measurable, and observable way, we want them to be better. And we want them to actually also experience that they were a key part in doing that they have that capacity to make those changes and to continue to choose commitments to actions that are going to move them towards what's valuable in their life and essentially be better versions than before they came in. Thank you so much for sharing your time today.
Wow, that was a very impressive presentation. Merci beaucoup, mesdames et messieurs. I appreciate the fact that you use evidence-based treatment and that you keep the veteran at the center of the program. Each program being built around the veteran and ensuring that the veteran himself or herself is part of the team is the perfect approach for people who actually always worked as part of a team while on the military service. So it makes a lot of sense to me, certainly. Now we're going to move on to the questions from the audience. Nous passerons maintenant aux questions. I'll start with you, Doug, first. What was the biggest challenge you had to overcome while going through your pain program?
The biggest challenge, I believe, would be the mobility. That was, I've had several falls. I threw my back out 3 times this year so far since Christmas time last year. Winding up in the hospital and out of the hospital. I mean, to gain mobility back again, that, I mean, yes, I did have another fall recently, but, you know, that was my neglect and not the fault of, that was my own fault. But the biggest thing is just being able to get around and be more mobile again, without that fear of actually falling and hurting myself. You know, I'm at home majority of the day. You know, I normally carry my home phone clipped right to my shirt in case something happens. So, you know, I mean, I don't do that anymore, but.
But if you compare it to the way it was before you started your program at CBI Health, it's completely different.
It's like night and day. I mean, I've gained that much more mobility around now. I mean, I feel more comfortable going places and doing things, you know, walking longer distances. you know, I've gained that much more strength back. And I mean, each day I gain more and more. Right. I keep pushing myself, and I will keep pushing myself to get back to somewhere's normal.
Yeah, right on, Doug. Thank you very much. I'm going to now go to Elisabeth and Tom and Eryn. How the question here is about case managers, and I think we listened in the other presentation of the same issues as how do case managers and veterans themselves learn about the program. And in this case of case managers, how does a case manager know what level of intervention would be required by the veteran in a pain management program?
So I think one of the key pieces is really about listening. And what that revolves around is not necessarily that a veteran's going to be speaking specifically around pain, but really speaking to those barriers. So if you're hearing that messaging that they're struggling with their community, with their relationships, getting daily activities done, when you hear those indicators, those are the barriers. And then the other piece is around not necessarily knowing exactly what they need. That isn't necessarily the responsibility of the case managers. It's really about knowing where to find out more information. So it's about making that initial referral for assessment and then allowing the team to do their job to be able to evaluate whether or not they need a more intensive program or in fact, they need something that's more single service based. So the assessment will actually be able to determine that for them.
Yeah, I'm going to add to this that I think from the research lens, there are a number of studies that discuss individuals who are candidates for pain management programs or those who have a sense of injustice around the pain, that there's changes in activity levels, day-to-day activities, daily living, social isolation, roles with family and community, sleep disturbance, and constant pain. And my advice for those listening to identify who is appropriate, think of Doug. Like Doug has highlighted so many of these. He discussed how he was becoming more socially isolated. He felt he was becoming more recluse, that mobility was problematic. It changed every aspect of his life. His pain was in charge, not him. And I think that is such a straightforward way to identify whom individuals are that are appropriate for this type of service.
Yeah, thank you. And as you can see now, we've gone 2 minutes over time, but I'm going to keep it going for a couple of more minutes because I think it's very important that we talk to some of those questions. And Tom, thank you for those comments. And what I really enjoyed, certainly one of the things I learned in your presentation was the fact that the idea is not to get rid of the pain, but it's to change the veteran's relationship with the pain. And I think that is such an important point. And I think from Doug's testimony, we saw that actually happened. In this case, Eryn, do you want to add something to that?
No, but I think that's an excellent point to highlight. And as we saw through Doug's testimony, he was able to speak to us about what he can do and some of those functional improvements, and not limited to what things he can't do because of his pain. And as we talked about in the presentation around the education and the intervention, now that engagement piece is starting to really apply all those techniques in the clinic as well as outside in the community.
Thank you. Now, I know that CBI Health also treats civilians. So have you seen many similarities or differences between the veterans and the civilians who have gone through the pain management program? Perhaps, Elisabeth, you could lead off.
So I think a lot of the commonalities are there, and Tom actually spoke to a few of these. We see the changes in mood, in sleep, in pain interference, that pain intensity. The reality is there are some notable differences. So we do notice that there are more points of pain, so more diffuse pain presentation in veterans. And often there are an increased level of comorbid mental health issues, whether that's depression. We've often worked with individuals who are concurrently attending the OSI clinic to address trauma and stressor-related disorders. So there are those significant differences. In terms of participation in the clinic, what I can say is we often notice that military determination that they go full bore, 100%. The engagement is there. They are committed. And sometimes, and I think Doug might be able to speak to this, sometimes we're actually having to tell veterans to ease off, and pacing is a really important strategy that we have to provide for them. And the last thing I'll say is in terms of that community piece, while there is interaction with other veterans, that interaction around engaging with non-veteran members who are participating in the program as well, I think is a good opportunity to sort of bridge that gap between not only being surrounded with other veterans, but being able to engage with others as well and learn from the shared experience.
Thank you. Doug, I don't know if you want to add something to this.
I'm fine.
Okay. All right, and I'll ask one last question, and that's the issue of how do you measure success? So a veteran goes through the pain management program, and how would you measure success? Perhaps, Eryn, you can lead off on this one.
Sure, I can speak a little bit to the barriers to reestablishment. So one piece specific to our Veterans Affairs pain management programs, we do look at that change in function from all of those domains that we mentioned. So looking at the level of independence with their activities of daily living, with the community participation, family roles, as well as their instrumental activities and vocational roles, that really helps us create some goals at the beginning of the program and track their progress through those 5 domains, as well as through their own goals. And I'll let Liz kind of speak to the other pieces.
So while we do look at success overall at the end of the program, I think it's important that the measures that we're using around pain catastrophizing, resilience, pain interference, as well as mood, we do use those throughout the program as well to sort of demonstrate that progress as it's occurring, but also to keep ourselves on track and to be able to say, okay, are we moving in the right direction? And if we're not, then it's time to pause, reevaluate, and see if there's a different intervention that we need to do. So it's great to have an outcome, but it's also important to use that as defining treatment and altering the program as needed going forward.
Yeah, I'm going to just add to this in a slightly different dimension. I think that there are a number of different clinical measures that are associated with successful outcome. And those are a great way to be able to measure. But pain is a multidimensional problem, and there is not a single ruler that really measures success. I think that what the other speakers have indicated is there are some clinical instruments that clearly look at what success is, but really where the rubber meets the road is where there is something that is important to a veteran to return to become more engaged with in terms of their life. That's how we end up really defining the success. It's those veteran-centric goals, and they can't be just around an aspect of their lives because this problem affects many aspects of someone's life. And so you need to have a couple of different markers of success.
Yeah, thank you very much. Listen, thank you very much to the entire team. This was very interesting. And thank you, Doug, as well, for encouraging other veterans to seek help, because sometimes getting the word out and needs to be done person by person. So well done there. So this is all the time we have, ladies and gentlemen. Thank you for all your presentations, for your answers to the questions, and for your research, which shows that there is indeed hope for improving the lives of veterans suffering from chronic pain and their families. The Chronic Pain Center of Excellence for Canadian Veterans will continue to perform research on the best ways to treat chronic pain, with the aim of bringing hope to all those suffering and to their families. As you saw with CBI Health, we emphasize interdisciplinary services for chronic pain management. You also may be aware that the center is creating a network of pain clinics across Canada. The 6 CBI Health clinics form part of this network. And as you saw with the testimony of Doug Zwicker, we encourage shared dialogue between the veterans and those who are providing them pain services. Veterans and their families can get help across Canada, and there are resources available, so there is hope. I remind you that a recording of this and all our sessions will be available on our website, and any question you might have can also be asked through our site. Please do not hesitate to contact us for any information you may require. So this concludes our series of webinars for this fall. So on behalf of the Chronic Pain Center of Excellence, thank you for your presence. Merci beaucoup à tous et à la prochaine.